Good afternoon. Thank you, Chairperson, for the introduction. Looks like there is a delayed recovery after lunch. Doesn't matter. Okay. So, yeah, my topic today is delayed recovery from anesthesia, not from lunch. Okay. So, we will cover our topic in the next 15 minutes with this following heading: definitions, protocol, the high-risk groups and causes which is responsible for delayed recovery, to identify and management protocol. Definition, the problem with the delayed recovery of anesthesia definition, we don't have a set society for it, like PONV society or regional anesthesia society or a difficult airway society. When you have a society, you will have a definition, you will have a protocol. But unfortunately, we don't have any set society for it. So there is no proper definition, but there is an understanding, or you can say a statement about the delayed recovery of anesthesia, which a generalized agreement which says that inability to regain an adequate level of consciousness by the patient, remaining unresponsiveness or deeply sedated 30 to 60 minutes after the end of general anesthesia. This is again an arbitrary 30 to 60 minutes depending upon various type of cases. In general, a simple ASA1 cases, simple general anesthesia cases, they are supposed to recover within 30 minutes. If it is delayed for more than 30 minutes, we call it as a delayed recovery, right? Let's see a two or three clinical scenario to understand what exactly is the delayed recovery. This is a 75-year-old male who's well-controlled hypertension, mild COPD. He was posted for robotic, total prostatectomy. The procedure was long and technically difficult, and total operating time was 5 hours. The patient managed with total intravenous anesthesia with propofol and fentanyl, a tracherium infusion. And at the 30 minutes before the procedure, there was increase in heart rate and blood pressure, so morphine 10 mg IV was given. At the end of the procedure, after cutting all the anesthetic agent, even after 60 minutes, patient is not erosible, but he is breathing spontaneously through the endotracheal tube. They did an ABG, which was around 48 millimeters of mercury. All other parameters were normal, but he is still not erosible. What can be the problem? We'll see at the end of the discussion. Scenario 2, it's a 100 kg patient, 150 centimeter tall, posted for shoulder dislocation for closed reduction. It's a difficult airway. Patient had taken food at 2 hours before surgery. It's in a semi-emergency. So it was induced with fentanyl and propofol, scoline 125 mg and intubated. Right, procedure finished in 7 minutes, but patient is not breathing, not recovering from the anesthetic effect or whatever it is. So they did all the investigation which was normal, train of 4 was done, a fade response was there. So how do we proceed? This is again a delayed recovery from anesthesia or whatever the cause. The third scenario, it's a 75-year-old diabetic patient posted for grade 2 amputation for SSG. Okay, he had some autonomic dysfunction, fluctuating blood sugar level. One day it was 350, another day it was 150. So autonomic dysfunction was also there. So they decided to do under general anesthesia with supraglottic airway insertion. His FBS was 120. He was case was taken at 12 o'clock in the afternoon. He was nil oral whole night. IGL was inserted with standard propofol, fentanyl, and sevoflurane. Duration of surgery was 60 minutes. No muscle relaxants were given. At the end of the surgery, even after switching off all anesthetic agent, patient is not responding to oral commands. His heart rate is normal. Saturation is 100% with 100% oxygen. So how do we proceed? Can the IGL be removed? Do we need to do any extra investigation before proceeding further? So we'll see that. So whenever we give an anesthesia, there will be recovery of consciousness. Recovery of consciousness is not limited to one organ or one system. There will be a stepwise recovery of consciousness. I'm not including neuromuscular blocker in this. When we give a general anesthesia to a patient, for example, we induce the patient with propofol 150 mg, fentanyl 125 mics, put them on oxygen, nitrous oxide and sevoflurane 2%, you can still do the procedure without any muscle relaxant. Let's say we've done that, okay, we have put the patient on that. At the end of the surgery, we switch off all the anesthetic agent and keep the patient on 100%. So the recovery will be in this following order. First thing will be respiratory drive. Remember, we have not given muscle relaxant. So the first thing to come back will be the respiratory drive. That is the first level of consciousness which starts. The following, that will be the sensory function, which will be written, which will be assessed by corneal reflexes. Then the brainstem function returns. That will be assessed by gagging, salivation, grimacing, and ocular movement. The fourth one will be improving the muscle tone. Not because we have given a reversal or because we have given a muscle relaxant, then we have given a reversal. It is not like that. Even with a general anesthesia, using a propofol sevoflurane, the muscle tone will be less. So the fourth function to improve will be the muscle tone. The fifth and the last will be the response to stimulation, eye opening, and spontaneous response to eye opening. So these last two, when the patient comes back, then we call the patient as recovered from general anesthesia, ideally, right? There are certain situations we would extubate the patient before that, but ideally a delayed recovery is classified when patient doesn't come back to this improving muscle tone or purposeful eye movement to command. So do we have any monitors to measure that there is a delayed recovery, to call it as a delayed recovery? We don't have a set monitor, but still Glasgow Coma Scale can be used. I know it is mainly used for trauma patient, but in case a delayed recovery can also be used. If the Glasgow Coma Scale is more than 13, that means patient is completely recovered. If he is intubated, the score is more than 10, that means patient is fully recovered. We can go ahead with the reversal process. Or modified Aldrich score can also be used. It's mainly used for shifting the patient from recovery to ward, but again from the OT table to recovery room, this can be used. With the score more than 9, we can safely say that patient has recovered from general anesthesia. Other monitors, train of phone monitor to assess the neuromuscular. BIS monitor will be a good monitor to assess the depth of anesthesia. Anything more than 90, we can say patient is fully awake. Gas monitor, the end-tidal inhalational agent, it should be less than 0.3, what we call it as awake MAC. Then we can say patient has recovered. Temperature monitoring, urine output monitoring, these are two important monitors which will tell the causes for delayed recovery. Blood glucose, ABG electrolytes, these can be used further when patient is not responding to our routine management protocols. Protocol, again, as I said, there are no society which has a standard protocol like difficult airway societies or PONV societies. So this is just institutional protocols which was published in British Journal of Anaesthesia 2020. How do we go about if there is a delayed recovery? The first and foremost will be to assess ABC. I thought I will zoom this. Unfortunately, the PowerPoint, that option is not available in this PowerPoint. Please excuse me for this problem. First, to assess ABC, airway breathing circulation, make sure that patient, this part is taken care of. Once it is done, then we will go to the monitoring part. You look for the end-tidal carbon dioxide as well as end alveolar gas monitoring. Less than 0.3 MAC or carbon dioxide is 35 to 45. You know that there is no problem with that. We will go to the next level. That is formal assessment. That is the GCS score, Aldrich score. All this scoring should be done. If there is a problem, we will go to the next one. What is the problem for this delayed recovery? What is the problem for this low GCS score? Then we will review the anesthetic chart, like preoperatively, was the patient has any risk factors or is there any causative factor which can cause delayed recovery. We'll also look for other investigations like ABG, electrolytes, all those stuff. If the top monitor shows a problem with the neuromuscular blocking agent, then a reversal can be done. Sugamadex was a theory before. Luckily, it is available in India. Sugamadex can be safely used if the patient, if you have used vecuronium or rocuronium, that immediate recovery will be there. Or you will go to the next set. If all these problems are not there in the patient, we'll go to the next level, that looking for the causative factor. Is there any risk factor or a causative factor for the delayed recovery? Right. So what are the causative? There are plenty. There are plenty which can cause delayed recovery, or that can be a risk factor or can be a causative factor. Among them, I have chosen only these smart ones which are responsible, most commonly responsible for delayed recovery. The first one is the extremes of age. I need not tell you about the problems of extremes of age. Extremes of age, when you say it is more than 75-year-old or less than 1-year-old. or elderly age group or an infant. We know that in elderly age group, because of the physiological changes, CNS, renal and hepatic changes will be there, which anesthetic drugs metabolism will be delayed. In infants, there is an immature organ system which cannot do the routine metabolic effect, so we will have a delayed recovery in infants. The other one which is responsible for delayed recovery will be genetic variations, right? Genetic variations are very low risk factors, but if it is there, it can be a dangerous one. The one which is South India, which is most common, is the abnormal or absent plasma cholinesterase, which results in prolonged effect of suxamethonium. Luckily, most of the places the suxamethonium has been stopped, so this problem should not occur if you have not used suxamethonium. Propofol we considered as a drug of choice for monitored anesthesia care or for daycare surgeries, but in certain Western populations, there is a polymorphic changes in GABA2 receptor which can result in prolonged propofol effect. It can cause delayed recovery. Luckily, it is not in the Asian countries, mainly in the Western countries, we will see that. Serotonin syndrome. Serotonin syndrome means a patient will be in it's a clinical diagnosis, patient will be in a coma, pupil won't be responsible, hyperreflexia, hyperhidrosis, right, deep coma. These should be suspected when the patient is on serotonin drugs like antidepressant drugs, plus you have given a drugs in the form of metoclopramide, ondansetron, fentanyl, tramadol. This combination can cause serotonin syndrome. The last one is the central anticholinergic syndrome. Whenever we see CACs, we remember atropine and anticholinergic drugs. It is not the only the anticholinergic drugs, even ketamine, propofol and fentanyl in adults can result in central anticholinergic syndromes. Surgical factors, there are a lot of surgeries which can cause a delayed recovery. The one most commonly nowadays, the fancy, is the robotic surgery. In the robotic surgery, you keep the patient steep Trendelenburg position. Any Trendelenburg position for more than 2 minutes, 2 hours can result in cerebral edema. Usually this will go for 5 to 8 hours. So you expect cerebral edema in such patients, so expect delayed recovery. Cardiothoracic neurosurgery, usually they are electively ventilated. Now fast track has been started, but in those patients, always look for temperature changes, electrolyte changes before extubating those patients. The other comorbidities which can result in delayed recovery, all the organ system. Any organ is affected, you expect to have a delayed recovery, especially the neuromusculars and the endocrine. Hypothyroidism, diabetes mellitus. So, okay, any endocrine problem, you expect a delayed recovery as well as neuromuscular disorders. These are the different pharmacological, metabolic and rare causes. This metabolic is one, hypoglycemia, hyperglycemia or hyponatremia, hypernatremia. They can also cause delayed recovery. The rare causes are the seizures, the myxedema, coma, brain stroke, all this can also cause delayed recovery, right? So I'll just skip this, the reversal agent, okay. I'll skip this since we don't have much time. These are the physiological signs we should remember whenever we are, recovering the patient from the effect of anesthetic. The first thing to come, as I said, will be the spontaneous respiration. Next, the heart rate and BP will increases, which will say that brainstem function is coming back to normal. Salivation, tearing begins. Non-localizing painful stimulation starts. Then the skeletal muscle tone increases. You would have given reversal agent, as well as because of the anesthetic effect slowly wearing off, the muscle tone improves. Then the eyes starts opening, which is the time where you will start extubating these patients. Again, this is how we follow this protocol. We have a New York Society of Regional Anesthesia. Even though it's a regional anesthesia society, they have given us a protocol how to prepare the patient for delayed recovery. The same, ABC check has to be done. You have to do Glasgow-Coma score as well as Aldrich score. If everything is fine, then you will give reversal drug in the form of, if there is a benzodiazepine overdose, flumazenil, if there is a opioid overdose, naloxone, if the neuromuscular problem, then sugammadex or neostigmine. Empirically, you can give glucose 25 to 50 ml or thiamine 100 mg IV. This thiamine is basically to prevent any encephalopathy. If with that also patient is not coming out, then you should look for very rare causes which can cause delayed recovery, right? This again, it's not a standard one, it's an institutional protocol which is followed in New York. the same thing can be used all over the places. Now coming back to those scenarios, the first scenario, we know that it is a robotic surgery, steep head down, probably a cerebral edema, plus they have given 10 mg morphine 30 minutes before the procedure, that too in a 75-year-old, probably opioid overdose, plus a TIVA, propofol. Maybe central anticholinergic syndrome can also be there in these patients. So this is how we follow this scenario. It's a simple one. Scoline was given. Even after so many hours, the patient didn't come out. TOF showed fade response. That means patient has gone into phase 2 blockade. You just have to electively ventilate and wait for the patient to come out. The third one, fluctuating blood glucose level. Patient was 60 minutes surgery. At the end of the surgery, even after switching off all the drugs, he is not coming out. Probably he is in a hypoglycemia. Look for blood glucose measurement, and you can extubate this patient once the glucose thing is corrected. Okay. To conclude, it's a difficult scenario, delayed recovery. We should have all the idea about the risk factors and the causes, and you manage a stepwise protocol, it will be easy to handle these patients. Thank you so much.